So I have made some slides for your easy understanding and in a way that you can write in your question paper also, right? First, I have covered introduction, history part, anatomy, epidemiology, etiology, etiopathogenesis, diagnosis and staging, and management. Introduction. Osteonecrosis, also referred to as avascular necrosis or aseptic necrosis and ischemic necrosis. Just a minute. Okay. And ischemic necrosis is not a specific disease, but rather a condition in which a circumscribed area of bone becomes necrotic as a result of loss of its blood supply. It is also known as Chandler's disease of hip and osteochondritis dissecans. Osteonecrosis is a death of living elements of involved bone, especially cells including bone marrow, with progressive destruction and alteration of bone architecture as a result of compromised vascularity. The process is purely aseptic but may be incited by loss of vascularity from infarction. History. Osteonecrosis was first described by Hippocrates circa in 400 before Christ. First case of aseptic osteonecrosis was described by Paget in 1970. Picard in 1985 stated this condition resulted from blockage of osseous microcirculation with intramedullary stasis and increased intramedullary pressure. This is the schematic picture of blood supply of femoral head. It is mainly from the three branches. First is the extracapsular arterial ring, which is major blood supply of profunda femoris. Second is ascending cervical branches of retinacular arteries of trueta. And third one is arteries of ligamentum teres, which is again a branch of foveal artery of obturator artery. This is the schematic diagram showing extracapsular arterial ring, which is mainly supplied by this one, lateral circumflex femoral artery as well as medial circumflex femoral artery. And there must be a minor contribution from superior as well as inferior gluteal arteries. Ascending cervical branches of extracapsular arterial ring, which is also known as epiphyseal arteries of trueta of retinacular arteries, arises from extracapsular arterial supply and ascend up into the neck, partly also supplying the neck in due course, which is divided into anterior and posterior as well as medial and lateral groups, which is shown here. Right? Lateral group is the most important group which carries the major portion of the blood supply to head and neck of the femur. In osteonecrosis of the femur, there are multiple hypotheses. The first is the Starling resistor, which is very much described in the rigid canister, where this is the rigid canister which was shown in this concept, and the thin-walled flexible tube which is compressed in this rigid canister. So while raising the pressure in a rigid wall chamber can decrease the fluid flow in a flexible wall tube which is passing through the chamber. In the case of the bone, the intraosseous extravascular compartment may function like a rigid wall chamber. Intraosseous hypertension or space-occupying tissue may sufficiently restrict microcirculatory blood flow to produce this ischemia. And intraosseous hypertension has been proposed to develop from various inciting causes and is considered the principal cause of ischemia in non-traumatic osteonecrosis. Epidemiology. The mean age of onset, it may be bimodal. It may occur in 20 to 30 second or third decades, and the second may be in the fifth or sixth decade, right? The male preponderance is more for non-traumatic osteonecrosis, but the ratio is higher for traumatic osteonecrosis as males seem to suffer high velocity injuries more. Atraumatic avascular necrosis is bilateral in 30 to 70%, but typically asymmetrical. This is the number of etiology, which is divided into traumatic and non-traumatic. The traumatic etiology you most common encounter in your casualty, which is most common, is neck femur fracture, posterior fracture dislocation, right? And non-traumatic causes are, first is the idiopathic. Second may be a genetic disorder. Third one is the drug induced. Most common is the high dose of the prolonged glucocorticoids, which or oral steroids. By history, you can get that patient has taken because of some skin condition, like. Then dyspareunism and gas emboli, which occur in caisson disease. There are innumerable metabolic causes. Then there are endocrine related disorders like Cushing's disease, pregnancy, hyperparathyroidism. Some hematological conditions, most common may be sickle cell anemia, and it also occur in some infections like systemic lupus erythematosus and other autoimmune disorders. The traumatic osteonecrosis, in which the dislocation of the hip, which occurs in 10 to 25%, or fracture neck femur, which leads to osteonecrosis in 15 to 50% of cases. The prompt relocation helps in reducing incidence of this osteonecrosis of the femoral head. The golden period should be 6 to 8 hours. That you should reduce this posterior hip dislocation, and you can get some revascularization, not 100%. The 52% hips dislocated for more than 12 hours develop osteonecrosis, compared with 22% of those reduced within 12 hours, which is described in some literature. The non-traumatic causes includes, first is dysmerism. It is also known as Caisson's disease or decompression sickness, which is most common in tunnel workers and other associated with deep sea diving in 1 to 4% of cases. The formation of nitrogen bubbles from the dissolved saturated nitrogen of the blood vessels due to sudden decrease in the atmospheric pressure precipitate infarction of the vascular capillary and eventually osteonecrosis. Second is alcoholism, which occurs, the incidence is 10 to 40%. There is increased risk of femoral head osteonecrosis in individuals consuming greater than 400 ml of alcohol per week. Alcohol induces increase in serum triglyceride and cholesterol levels, along with liver and bone marrow fatty infiltration. There may be pycnosis in osteocytes that alter the size and shape of the osteocytes due to triglyceride deposition, and ultimately death, leading to an increased percentage of empty osteocyte lacunae. This undergoes apoptosis, so there is a destruction of these osteocytes. Hyperlipidemic states which enhance thrombosis. This is the schematic picture which shows the high dose of alcohol consumption which occurs, which affects the vascular channels of liver as well as the intramedullary vascular channels, and which doing two things. The mechanism is accumulation of the lipid droplets in bone marrow, that is one, and second is the fat embolism in the bone microvessels. So histologically you can see there is lipid droplets in the osteocytes, and there is a pycnosis, and ultimately it leads to osteocyte apoptosis. Some hemoglobinopathies, most common is sickle cell disease, which 20 to 68% causes this avascular necrosis, which is most common in South Gujarat. Hereditary thrombophilia as well as antiphospholipid antibody syndrome can lead to sludging, thrombosis, and eventual infarction at capillary level. Some common drugs like steroids, phenytoin, and indomethacin can cause avascular necrosis. Steroid induces 10 to 13% of cases. Glucocorticoids are most common cause of non-traumatic osteonecrosis. The mechanism, again, the proposed hypothesis emphasizes small vessel occlusion by fatty emboli and increased impedance of sinusoidal blood flow secondary to rise in intraosseous pressure and venous obstruction. Patients receiving steroid therapy have an approximately 20-fold increase in their likelihood of developing osteonecrosis. This is again a mechanism which is patient has taken steroids. The antioxidant enzymes are in lower level, so the oxidative stress it is increased, that will form osteoclast, and osteoclastic activity is increasing. That will lead to augmentation of some enzymes, increased osteoclastic activity, empty osteocyte lacunae, and altered bone structure. That will lead to osteonecrosis. Some collagen diseases, most common is rheumatoid arthritis as well as systemic lupus erythematosus, in which the mechanism may be inflammation of small peripheral blood vessels which promote formation of vascular thrombosis as well as tissue infarction. The radiation. The necrosis is primarily induced by vasculitis, which is caused by radiation that leads to thrombosis and occlusion. Capillaries are also damaged directly by radiation, and endothelial damage makes them leaky, which leads to development of bone edema and further compromise vascular perfusion. A threshold dose of 3000 radiation is permissible. Idiopathic causes. Most common cause of osteonecrosis is idiopathic. The factors rendering bone liable to infarction at its articular edge. Because there are small diameter of terminal vessels in subchondral region. Second is lack of collateral circulation in the subchondral region. Third one is reduced blood flow in bone with high marrow fat and inexpandable nature of the bony tissue, which is very much described in Starling register. The bony compartment function essentially as a closed compartment within which one element can expand only at expense of others. Vascular occlusion and venous stasis leading to osteocyte necrosis, which play a central role in pathogenesis of avascular necrosis. This is a picture which shows traumatic as well as non-traumatic etiology. The non-traumatic etiology shows steroids as well as alcohol, which are the most common factor which causes avascular necrosis, in which the intraosseous lipogenesis occur, lipocyte proliferation and compression of the vessels, as well as increased intraosseous pressure and venous stasis, which again leads to death of the cellular component. In hypercoagulation disorder, there is a vascular hypothesis in which thrombotic occlusion or embolism that will leads to fat emboli and complement activation that again leads to collapse of the bone. Traumatic etiology, you better know, only vascular disruption at the neck of the femur or extracorporeal extra-articular ring or in the retinacular arteries of trueta. And in this location, there may be a foveal artery disruption. And irradiation, there is a direct damage and death of the cellular component. Pathogenesis. First is the hypoxia of the retinacular or intraosseous vessels. This will lead to increased cell membrane permeability, which allows fluid and electrolytes to enter into the cell, causing it to swell. Lysosomal enzymes are released, autodigestion or coagulation necrosis and cell rupture. Vascular injury leads to tissue edema and hemorrhage. The inflammatory response ensues, which causes disappearance of osteocytes from within their lacunae, which leads to center of the necrotic lesion remains avascular and repair is not possible. And repeated stresses causes dead trabecula undergo microfracture that cannot be repaired. Then transition zone at the periphery. This histology shows some pictures of transition zone as well as some lacuna changes. Macrophages infiltration are also seen. Macrophages and osteoclasts remove dead marrow element and bone, and ultimately granulation and fibrous tissues are formed. The osteoblasts form new bone, which is laid down directly on remnants of the dead trabecula. The resulting trabeculae are much thicker than normal, so they are immature trabeculae, which is responsible for the sclerotic margin that surround the lesion. There may be a small lesion or a larger lesion. Small lesions, which is not in the major weight-bearing region, so revascularization and completely replaced by viable bone. But larger lesions, particularly those in the region of the major weight-bearing area, have a poor prognosis because they are irreparable and gradual collapse occur. If the contour of the articular surface remain intact, a fluid-filled space beneath the cortical subchondral bone develops, which gives the appearance of a crescent sign on radiograph, which is seen in grade 2B. The mechanical stresses on the collapsed and irregular articular surface leads to damage and death of the chondrocytes. These abnormal stresses are transferred to the otherwise normal cartilage of the acetabulum, secondary degenerative changes, which leads to grade 4 changes. Then joint space narrowing as well as typical changes of degenerative joint disease appear, which include sclerosis, cyst formation, marginal osteophytes in acetabular region, and end-stage arthritis of the hip eventually ensues. These are some histopathological stages. In stage 1, which is apparently normal on radiography as well as in MRI picture. So, but in histopathology, it shows on gross anatomy, necrotic wedge-shaped, dull, chalky, opaque and yellow subarticular lesions which are well demarcated. And microscopically, you can see cartilage, normal cartilage, subchondral bone shows eosinophilic changes, which late cellular elements and osteocytic lacuna are empty. The margins of the infarcts shows increased osteoclastic activity with infiltration of the granulation tissue, which is shown in the picture as a thin red ring. And beyond infarct and hypervascular zone, bone and marrow remains unchanged. This is stage 1. Now in stage 2, the articular surface remains intact. The gross anatomy shows there is a ream of bony sclerosis at the boundary between necrotic zone and the unaffected zone. On microscopy, it shows advancing front of the granulation tissue, following which second front of the osteoblasts. It shows creeping substitution, which are encroaching towards the subchondral region and increased vascularity with osteoblastic activity and new bone formation. In stage 3, there is alteration in shape of the articular bone. The it shows buckling of the articular cartilage. It shows in the picture, and in the cut section histologically, in the cut section it shows the fracture just below the articular end plate or in the necrotic side of the advancing sclerosis in reparative front. Fracture occurs due to the weakening of the trabeculum due to increased osteoclastic activity. In stage 4, it is in advanced stage. So on gross, it shows articular deformity. On cut section, it shows residual fragments of articular cartilage and dense fibrous connective tissue in the area of the infarction. Articular surface, dense sclerotic are eburnated and osteoarthritic changes. Clinically, patient present with some pain. It may be a dull aching pain, or if it is in advanced stage, so there is a gait changes. So intense and sudden in onset, as in infarct, or it can be insidious and chronic. Groin pain, but radiating to anterior and anteromedial thigh, which is less common to posterior aspects. Pain present at rest, which worsens with motion and weight bearing. On examination, patient present with antalgic gait, decreased range of motion at the hip, particularly in the flexion and internal rotation. The sectoral sign. Patient lies supine, and you can supine or in the prone, and this shows the sectoral sign is positive when the range of the internal rotation is less in hip flexion compared to hip in extension. Second is image. Investigation part is imaging, the radiography, AP view as well as the frog leg lateral view. The initial radiograph will be normal in stage 1. The sequela shows crescent sign in the weight bearing portion. Second is sclerosis, some cystic changes, loss of spherical weight bearing dome, partial collapse of the head, and in advanced cases it shows secondary osteoarthritis, whether in the femoral head as well as in the acetabular side. This is the Kerboul necrotic angle. This is measured from the anteroposterior view as well as the frog leg lateral view of plane radiography, and it is a summation of the angle of the area of destruction, arc of destruction in AP as well as lateral view. So it is determined by measuring the arc of the articular surface overlying the lesion on anteroposterior and lateral radiographs. These two are added and referred to as the combined necrotic angle. So it is, if it is more than 200, it is a large lesion. If it is 150 to 200 in the range, then it is a medium lesion. And if it is smaller than 100, smaller than 150, then it is a small lesion. Then MRI. The abnormalities in the femoral head on MRI can be made out as early as 7 to 10 days after the onset of the symptoms. It has the better precision because it has a high sensitivity as well as specificity. A low intensity signal band on both T1 weighted as well as the T2 weighted images. The early abnormality can be picked up by MRI. In more advanced lesion, T1 images continue to show low intensity signal, but T2 images may exhibit signals of alternating high and low intensity, which is called as double line sign. So this is shown in the T1 as well as the T2 images in the advanced stage in T2 image. Now the staging. First is the Ficart-Arlet classification of the osteonecrosis of the femoral head. This is the summation of all the things: clinical signs, radiography, bone scan, as well as the biopsy. So in stage 0, there is the bone scan shows decreased uptake. In stage 1, the symptoms are very mild. Patient present with mild groin pain. Radiography is normal, but bone scan shows cold spot in femoral head. Pathological finding shows infarction of the weight-bearing portion of the femoral head. And on biopsy, you have shown in the stage 1 the abundant dead bone marrow cells, osteoblast and osteogenic cells. In stage 2, the symptoms are again mild. The radiography may be normal or may show density changes in the femoral head. Then bone scan shows increased uptake because there is a vascular stasis, so it shows increased uptake, right? The pathological finding shows spontaneous repair of the infarcted area, and the biopsy shows new bone deposited between necrotic trabecula. In stage 2, there is subgroup stage 2A and 2B. The symptoms may be mild to moderate. The radiography shows in 2A sclerosis or cystic changes. Joint line is again normal, and there is a increased uptake on bone scan. In stage 2B, you can see the flattening and the crescent sign. In stage 3, you can see mild to moderate symptoms. On radiography, you can see the loss of sphericity and collapse, but again the joint line is normal, more or less normal. Bone scan shows increased uptake. Pathological finding shows subchondral fracture, collapse, compaction and fragmentation of the necrotic segment, and biopsy shows dead bone trabecula and marrow cells on both sides of the fracture line. On stage 4, it is advanced stage, so the symptoms are also severe. Then radiography shows joint space narrowing, acetabular changes, increased uptake on bone scan. Pathological finding shows osteoarthritic changes and degenerative changes in acetabular cartilage on biopsy. This is another classification, Sternberg University of Pennsylvania, in which the stage 0 shows normal radiography and normal bone scan. This is again a summation of the classification. Stage 1 is normal radiograph, abnormal bone scan. Stage 2 shows sclerosis and cystic formation in the femoral head, in which it is subdivided into mild, moderate and severe, less than 20%, 20 to 40% and more than 40%. Stage 3 shows subchondral collapse and crescent sign, which was seen in grade 2B in Ficart-Arlet stage. Again, it is subdivided into mild, moderate and severe, less than 50%, 15 to 30% and more than 30%. Stage 4 shows flattening of the head without joint narrowing, in which it is subdivided into mild, less than 15% of the surface and less than 2 mm depression. In moderate, 15 to 30% of the surface area are flattened of 2 to 4 mm with 2 to 4 mm depression, and in severe cases more than 30% of the surface of more than 4 mm depression. In stage 5, the flattening of the head with joint narrowing, which is determined as for stage 4 plus estimate of the acetabular involvement, which is again mild, moderate or severe. And in stage 6, it is advanced stage for sclerosistic changes. Point counting on a grid determines person involvement of the head. For crescent sign, planimetric assessment is performed on AP and lateral radiograph, and for articular flattening, crescentic circles are used to assess the percent of the head flattening. This is the Pittsburgh classification of osteonecrosis, which is again based on the MRI as well as the radiograph. Stage 1 shows abnormal MRI with normal radiograph, in which less than 30% and more than 30% involvement of articular cartilage on MRI. Stage 2 shows abnormal MRI with some contour, femoral head contour changes on radiography, and stage 3 shows everything is abnormal with less than 30% and more than 30% involvement of the articular cartilage. CT scan. It can visualize a small lesion not easily seen on routine radiograph, and it may demonstrate small areas of articular surface collapse that are not apparent on plain films. It may also be used to help quantitate the extent of the femoral head involvement. This is the CT scan changes. It is not used commonly in avascular necrosis of the femoral head except in traumatic cases. Bone scan, with technetium labeled phosphate analog used for early detection of the osteonecrosis. It is not as sensitive as magnetic resonance imaging. During acute phase, it shows decreased uptake of bone tracer associated with vascular compromise and increased accumulation in chronic venous stasis in repair and revascularization in advanced stage from grade 2. It can be useful especially in assessing the status of multiple joints. This area shows increased uptake on bone scan. Now the management part. What are the goals of management in osteonecrosis of the femoral head? First is the relief of pain. If you should grade according to the classification, then you can give some analgesics, rest to the hip joint if it is in the early stage. Then the second goal is the arrest of the already ongoing progression of the disease, like with some bisphosphonate or with some non-invasive methods. Third is prevent the already collapse of the head. If it is in the grade 2A or grade 2B, you can further prevent the collapse by some semi-invasive methods. And last is to prevent the secondary degenerative arthritis. This chart shows the treatment modality and overview. The non-operative conservative line of management includes non-weight bearing, biphosphonate therapy like risedronate, alendronate, or ibandronate. Then third one is anticoagulant therapy, statins and other vasodilators depending upon the etiology. Then extracorporeal shock wave therapy as well as pulse electromagnetic therapy and hyperbaric oxygen, which is under research. And operative therapy are core decompression, mesenchymal stem cell implantation, non-vascularized bone graft, porous tantalum implant, vascularized bone graft, proximal femoral osteotomy, and last is arthroplasty. This is the algorithm of the osteonecrosis femoral head management. Patient present with the hip pain with presence of risk factors in young patient. Then the bilateral hip joint radiograph, both hip and pelvis shows radiographic features suggestive of the osteonecrosis. Then you should stage according to the Arco stage or Ficat-Arlet staging, which includes clinical examination, radiography and MRI. If it shows subchondral cyst and sclerosis, which might be a grade 2A or 2B, so you can plan for some core decompression, non-vascularized bone graft along with biphosphonate or extracorporeal shortwave therapy. Or in advanced stage, you can also plan some non-vascularized bone graft. And if the patient is too young, then you can think of femoral head salvage surgeries like osteotomy, varus or valgus osteotomy or McMurray osteotomy. If the patient shows subchondral fracture with or without collapse, then you can also plan for, if the patient is too young, then you can plan for non-vascularized bone graft. If the patient is middle-aged to old age, then you can plan for surface replacement or total hip arthroplasty. If it shows on radiograph or upon the stages the femoral head collapse, secondary arthritis of hip joint as well as acetabular involvement, then you can directly do total hip replacement. If radiographies are not suggestive of any osteonecrosis, but MRI suggestive of osteonecrosis, then you can again plan according to the femoral head osteonecrosis management according to the age. And if it is MRI is normal, then search for the other causes like infection. Non-operative treatment. Non-operative management of the osteonecrosis femoral head includes restricted weight bearing in early stage, Pharmacological agents, as we have discussed, like anticoagulants, statins. Then second is biophysical modalities of the treatment, like uh, extracorporeal therapy, as well as pulse electromagnetic therapy. The goal of the drug treatment in the pre-collapse stage is to improve the hip function, then provide pain relief, prevent radiographic progression to subchondral fracture and collapse, and fourth is the allow healing of the necrotic lesion. Uh, Restricted weight bearing using cane or crutches or a walker is effective in early stage of osteonecrosis. When the osteonecrosis lesion is less than 15% and located far from the weight bearing dome. If it is in the medial lesion, then you can advise some non-weight bearing and it is useful. In one-third of the patient with small or medium-sized lesion, but it should be less than 50% of the head involvement, progress to symptoms or collapse in spite of the non-weight bearing, whereas large lesions have more chances of disease progression. Progression of the advanced stage depends largely on the location, size of the lesion, and underlying etiology. Therefore, non-weight bearing modality of the treatment cannot be accepted as a standard isolated modality of treatment and may be an additive treatment to medical or surgical management. Non-weight bearing, this therapy decreases the degree of the discomfort in patients who are symptomatic. They have not been shown to alter the natural course of this disorder. Following certain types of the surgical procedures such as core decompression, vascularized or non-vascularized bone grafting, and osteotomies, where it is used as an adjunct. And it also protects the weakened region from fracture and perhaps protect the femoral head as well until the healing processes have progressed satisfactorily. Bisphosphonate. Bisphosphonates promotes bone healing by inhibiting osteoclastic activity in osteonecrotic lesion site. It prevents collapse in early osteonecrotic hip or prevent onset of the subchondral fracture. In advanced condition where collapse has already taken place, it delays the need of total hip replacement surgery in young age. Therefore, alendronate in osteonecrosis femoral head patients can be used in dose of 70 mg weekly for 3 years in stage 1, 2 and 3. Anticoagulants, statins and other vasodilators. Thrombophilia and hypofibrinolysis leads to venous stasis and reduced arterial flow, thus increasing intraosseous pressure and hypoxic bone death, which has been postulated as a major common etiological factor for osteonecrosis. Systemic anticoagulation therapy started before irreversible segmental collapse of the femur head may arrest or speculatively sometimes reverse the process of ischemic osteonecrosis. Lipid-lowering agents are also helpful in steroid-induced osteonecrosis. Steroid causes hyperlipidemia, which increases the fat content and also increases intracortical pressure, which leads to sinusoidal collapse and osteonecrosis. Statins are lipid-clearing agents that dramatically reduce lipid levels and blood and tissues. Adrenocorticotropic hormone also shows some protection against steroid-induced osteonecrosis. It enhances osteoblastic activity and stimulates vascular endothelial growth factor that enhances neovascularization in femoral head. Extracorporeal shockwave therapy. This enhances neovascularization by stimulating the expression of angiogenic growth factors, but the exact mechanism is not clear. It has been compared to core decompression and found to improve function of hip to a greater extent. It can be used as an adjunct with hyperbaric oxygen therapy and bisphosphonates. Pulse electromagnetic therapy, it is same, which affect favorably in early stage osteonecrosis through stimulation of osteogenesis and angiogenesis similar to extracorporeal shockwave therapy. It can be used as an adjunct to core decompression as well as oral bisphosphonate. This is a good picture I have found of therapy of hyperbaric oxygen, which is not used in our country, but it has a beautiful mechanism. It improves oxygenation, it reduces the edema by vasoconstriction, it induces angiogenesis and reduces intraosseous pressure and improve microcirculation. The procedure is patients are sit in this closed chamber, 100% oxygen at 2 to 2.4 atmospheric pressure for 90 minutes by mask for about 100 days to the patient of early stage osteonecrosis. Bone marrow infiltration. The small number of progenitor cells in the proximal extremity of the femur with osteonecrosis causes insufficient creeping substitution after osteonecrosis. Red bone marrow graft contains osteogenic precursors which help in reparative process. This is used in adjunct to core decompression. Now the operative treatment. Surgical treatment for a pre-collapse stage osteonecrosis involves heap preserving procedures like core decompression, non-vascularized bone graft, vascularized bone graft, whereas prosthetic hip surgery is reserved for advanced stage or collapse stage and arthritic hip. Core decompression. Core decompression is the most commonly performed surgical procedure for treatment of early osteonecrosis of the femoral head. The mechanism of the procedure shows decreases intraosseous pressure. Second is increases blood flow to the necrotic area. And third one is it augments new bone formation. Core decompression is currently the gold standard management of stage 1 and stage 2 osteonecrosis, means in the pre-collapse stage. It has been cost-effective surgical procedure for osteonecrosis of the femoral head. The success of the treatment is largely depend on etiology, lesion size, location, or collapse of the lesion. There are two types: the conventional core decompression, which is with the wide bore cannula, and novel one, which is done by the K-wire or Steinman pin or small diameter cannula. Conventional core decompression is performed using 8 to 10 mm cannula or trephine. The disadvantage of conventional core decompression carries potential risk of subtrochanteric fracture and hip joint penetration because of the wide bore penetration on the lateral cortex of the femur. The novel procedure, this novel procedure is done by multiple small drilling, 3 mm diameter, which has shown better results than the conventional core decompression. The small diameter drill can more easily reach the anterior portion of the femoral head that is commonly involved with osteonecrosis. There is less risk of fracture, small incision, and minimal morbidity. The risk of bone weakening and articular surface penetration is considerably reduced. This first picture shows the conventional core decompression, where in the lateral cortex you can see the wide bore cannula or some 8 mm drill. 8 mm drill, it is drilled up to this area. And in this novel procedure, you can see you can drill in multiple directions. On APN lateral view, you can see this is in the multiple direction in anterolateral, superolateral as well as postero-superior region, where the cystic changes or crescent signs are present. By this drill, you cannot reach up to this area in the weight-bearing portion, and by this one, you can reach to somewhat this area where the stage 2A or 2B is addressed. So postoperatively, patients are kept on protected weight bearing for about 6 weeks following conventional core decompression and about 3 weeks when drilled with smaller drill holes. Mesenchymal stem cell implantation. This is again it is used as a ACI that you are using in the femoral articular defect, autologous chondrocyte implantation, as well as in the patellar defects. It augments osseous regeneration in the necrotic lesion site. There is application of osteogenic or angiogenic precursor cells with or without growth factor. Mesenchymal stem cells derived from adult tissue represent a highly promising option for the treatment of osteonecrosis femoral head in the pre-collapse stage. Mesenchymal stem cell implantation has capability to differentiate into multiple cell lineage, including osteoblast, chondrocyte, and adipocytes, and this implantation can be used as an adjunct to core decompression. Bone grafting. Various authors have claimed success rate up to 50 to 80% after core decompression with structural bone graft. Non-vascularized bone graft can be used in Fica Darlet grade 1 or grade 2. Accurate placement of the graft within the lesion and under the subchondral bone is utmost important. Standard core technique or light bulb technique or trapdoor mechanism can be used. It is described here. This is the trapdoor mechanism where the bone graft, where the anterolateral or posterosuperior region after safe surgical dislocation of the hip anteriorly or posteriorly, this area is debrided and the bone graft is put. So this is the trapdoor mechanism. And second is the light bulb mechanism, where light bulb technique, where the anterior or posterior cortical window is made here. You can drill this area like you drill in the core decompression, and you can put some graft here and close this area with the anterior or posterior femoral cortex, cortical window. The non-vascular bone graft, tibial autograft or fibular autograft or allograft are used to support the subchondral bone and articular cartilage after removal of the necrotic lesion from the femoral head. The osteoconductive and osteoinductive properties of the bone graft help in inhaling of the osteonecrotic lesion. This modality of the treatment is indicated in pre-collapse and early post-collapse where the lesion or collapse is less than 2 mm, osteonecrosis of the femoral head, where articular cartilage is relatively undamaged. The techniques are again the Femister technique, grafting through core decompression tract. You do a core decompression, standard technique, conventional method, and you can put a large 6 to 8 mm fibular graft. That is the Femister technique. Second is trapdoor technique as well as the light bulb procedure. Rarely used as an isolated procedure, is usually combined with growth factors and various bone graft substitutes. Porous tantalum implant. These implants provide structural support similar to that of the bone graft. The porosity of this rod allows secure and rapid bone growth. Efficacy of porous tantalum rod can be further improved by addition of bone marrow growth factors or bisphosphonates or mesenchymal stem cells. This avoids the risk of infectious complications and donor side morbidity as seen with the use of allograft and autograft respectively. Vascularized bone graft. Vascularized bone grafting is recommended modality of treatment for early osteonecrosis of the femoral head. It can be used up to grade 3. The graft provides a viable structure support and prevent joint collapse. Vascularized bone graft has osteogenic potential which augments bone healing in the necrotic lesion site. The examples are vascularized iliac crest graft, vascularized fibular graft, or muscle pedicle bone graft. That is the Mayer's technique. The muscle pedicle bone graft. Mayer's was the first who reported application of muscle pedicle bone graft for treatment of osteonecrosis of the femoral head. After incorporating cancellous bone graft over the necrotic lesion, quadratus femoris muscle with bone in its insertion is elevated and placed over the necrotic lesion and fixed with the cortical screws. Vascularized fibular graft. The rationale of this technique is to decompression of the femoral head. Second is excision of the sequestrum and filling the defect with osteoinductive cancellous graft and viable cortical strut. A longer recovery period and less uniform and less complete relief of the pain with this procedure, as according to the literature. Success rate shows 80 to 91% for younger symptomatic patients without collapse. This is the technique which is used whether with the Watson-Jones technique or with the Hardings. You can expose this lateral aspect of the femur. You can do a drill hole. You can isolate the lateral circumflex femoral artery and vein. Then you can take some midshaft of the fibula depending upon your length and diameter along with the peroneal artery and its vena commitants, and it is anastomosed with this lateral circumflex femoral artery. Now the proximal femoral osteotomy or McMurray osteotomy, it can be used in the younger age as a bone salvage procedure. The principle is mobilization of the necrotic bone of the femur head away from the load bearing area. So it causes offloading, replacing it with the uninvolved healthy portion of the head. It reduces the intraosseous venous pressure and improves vascularity. There are two types, transtrochanteric rotational osteotomy, and the second is intertrochanteric varus or valgus osteotomy combined with flexion or extension. The make-Murray osteotomy, it was used in the past, especially in the developmental dysplasia of the hip, as well as the coxa vara of the uh, hip. Thomas Porter McMurray became famous for introduction and osteotomy for treatment of non-union of fracture neck of the femur, but later on also advocated for fresh femur neck fractures and osteoarthritis of the hip. It is an intertrochanteric oblique osteotomy of the hip, where the distal osteotomized femoral shaft is displaced medially under the neck and the femoral head. So this femoral shaft is displaced medially. The osteotomy is done here. The entry point is below the lesser trochanter, and the exit above the lesser trochanter. This osteotomy starts from lateral femoral cortex just below the level of the lesser trochanter and proceeding obliquely to finish medially just proximal to the lesser trochanter. The inward pull of the psoas major muscle helps in maintaining the medial displacement of the distal femur under the femoral neck and head. These are the again valgus osteotomy for anterolateral lesions and varus osteotomy for central or supromedial lesions in younger age group. This is again a Sujioka transtrochanteric anterior rotational osteotomy, which describes the transposition of the necrotic portion of the femoral head antero-inferiorly away from the weight-bearing area, which is shown here. The weight-bearing area shows the necrotic region, and it is rotated here. So the weight-bearing area becomes this sound one. But it has again, this osteotomy has again more complications of avascular necrosis of the femoral head in different area. So it is not commonly done. This Sujioka osteotomy is not commonly done. Now the arthroplasty, the gold standard treatment. The arthroplasty is the final treatment when all other modalities of treatment have failed or joint is arthritic secondary to advanced collapse more than 2 mm or grade 3 or grade 4. Avascular necrosis of the head of the femur forms one of the major indications for total hip replacement. Between 5 to 12% of the total hip replacement are performed in the patients having avascular necrosis of the femoral head. Indications are patients with advanced osteonecrosis, stage 3, of any age, but less than 30 years of age. It may be still considered as an alternative procedure of head salvaging. Second is older patients more than 50 years with stage 3 or more, combined necrotic angle more than 240. So it is a larger lesion where the failure rate of the other procedures is significantly higher, and all cases of the failed previous surgeries. Contraindication not to be used in all those patients who can be reasonably managed with joint preservation procedure for early stage disease, and very young patient less than 30 years of age. Cementless total hip arthroplasty has reassuring results in patients less than 60 years of age with no other associative hip pathology. Whereas patients with more than 60 years of age, they achieve better results with cemented total hip arthroplasty. Arthroplasty, total hip replacement is a very large topic, but I have concluded with some slides. There are different designs and materials in hip replacement, which consist of two basic components, ball and socket component. Ball component consists of highly polished metal and ceramic material. Socket component is highly cross-linked molecular weight polyethylene, ceramic or metal. Metal may be cobalt chrome alloy or molybdenum. Total hip replacement should be cemented and uncemented. Decision is based on factors like age, quality of the bone, strength of the bone, and affordability of the patient. The first is the metal on poly. The metal is cobalt chrome alloy with molybdenum femoral head on polyethylene acetabular liner. The benefits of metal on poly are longest track record of bearing surfaces with lower cost and most modularity. The disadvantage is higher wear and osteolysis rates compared to metal on metal and ceramic. Smaller head compared to metal on metal leads to higher risk of impingement. Now, metal on metal. The benefits and merits are better wear properties than metal on poly, lower liner wear rate, debris particles much smaller but more numerous than those of metal on poly, overall smaller volume of particles, and larger head allows for increased range of motion before impingement. The disadvantages are more expensive, increased metal ions in serum and urine, which is 5 to 10 times normal and highest at 12 to 24 months. It correlates with the initial wear in or run in phase of increased particle generation, but then followed by a steady state phase of decreased particle generation. It may form pseudo tumors in and around the hip, hypersensitivity of type 4, and which is mediated by T cells. So ceramic on ceramic. The benefits are best wear properties of all bearing surfaces, metal on metal as well as metal on poly, lowest coefficient of friction of all bearing surfaces with inert particles, no concern for cancer risk. Disadvantages are first is the more expensive. Second is worst mechanical properties like alumina is brittle, low fracture toughness. A small 28 head only exists in zirconia because of the alumina's inferior mechanical properties. Squeaking are seen after some time, after 24 to 36 months or longer. Impingement and acetabular malposition, third body wear, loss of fluid film lubrication, uh, thin and flexible stems are available, less modularity with fewer neck length options, stripe wear caused by contact between the femoral head and rim of the cup during the partial subluxation. This results in a crescent shaped line on the femoral head. Thank you.
Thank you, sir.
So this is a very common topic for all of you.
Yes.
And this is not a direct diagnosis, okay? It is secondary to some underlying etiology that I have described, traumatic or non-traumatic etiologies, right? And it is a most common differential diagnosis also. So remember that, okay?
Okay.
Read it today, please, so that you can remember longer. Okay. Thank you so much again. The whole team of Gujarat Adani Institute of Medical Sciences, respected director sir, dean sir, respected head of the department of orthopedics, faculty members, dear colleagues, and whole admin staff of Adani Institute for organizing this wonderful platform on online mode in this difficult situation. Thank you so much.
Thank
you.
ચલો ગંદી આવે તમારો